All right, I think we'll go ahead and get started. Good afternoon again, everyone. I'm Debbie Condry, the COO for the Sequoia project. It is my distinct pleasure this afternoon to be here with Nora Belcher and Adam Harrell, and they are the co-chairs of our Emergency Preparedness Information Work Group, which is one of our Interoperability Matters work groups under that program. So we want to today talk to you a little bit about what's been going on in the Emergency Preparedness Information Work Group, why we came about, what our purpose is, what are some of our exciting plans for the future. We do have a pandemic response white paper that was released earlier this year, which was very well received, and we want to go through some of those recommendations that came out of that white paper as well. And then we're just going to have a bit of a conversation about sort of our plans for 2023, getting more engagement in our work group, potentially expanding the scope of the work group, et cetera. So I'm going to spend a little bit of time with just some, let me get to the slides here. Okay, just a little bit of time just sort of prefacing all of this before I hand off to Adam and Nora. And Adam and Nora are going to introduce themselves a little bit more fully, and they're also going to give you some background on what led them here, what led them to emergency preparedness, to the work they do in healthcare, to the work they do for the citizens of Texas and Virginia, and why is this their passion, and how are they applying this passion to this work group and this work that we're doing. So as I said, it's a distinct pleasure to work with both of them, and we so appreciate them being here today. So I know that you all have probably heard about Interoperability Matters and the program that Sequoia runs. We have a few slides that sort of preface the report itself. So I want to tell you a little bit about Interoperability Matters before we move on, and the fact that it's a public-private cooperative that solves discrete health information exchange challenges. The Emergency Preparedness Information Work Group is fairly new to this group of work groups. We were thinking about this right about the beginning of the pandemic and how we could be additionally helpful in the public health and emergency preparedness space, especially as public health was called to just an incredible situation in dealing with a pandemic that I know we probably thought we would never see. So we at Sequoia were thinking about what can we do to be helpful? What are some of the discrete challenges that are happening with public health that we might be able to step up and be helpful either at a state and local level or even at the national level? What are the things we can talk about at the national level in terms of HIPAA, for instance? And I know much of public health found this to be true during the pandemic is, how do I get all the clinical information I need as a public health entity in order to make sure I have enough information about a COVID positive patient who needs care? And is that all of the patient information or clinical information, or how does that work? And then there's the idea, obviously, of minimum necessary within HIPAA and how that applies to public health and state health officials having to declare the need for additional clinical information state by state. So a cumbersome situation. So we had a work group in place already that was driven out of our work with the Pulse program a few years ago. So we decided to revamp the Pulse program and came up with the Emergency Preparedness Information Work Group. And we are very pleased to say that the members of our work group, most of them were volunteers. We did go after a few people, and we might go after some of you in the room to participate with us. But subject matter experts, and what's so nice about this work group as well, it's subject matter experts with really boots on the ground experience, and they're in the middle of it. They're in the middle of providing emergency preparedness response. Adam is our co-chair, works with emergency medical services, is an EMT. He is in the middle of providing direct boots on the ground care and has real life experience that we're really applying to the work that we do. So let me skip through. I know you've heard feedback today from the various work groups, the data usability work group. Congratulations to that work group for launching their IG today. That's incredible work. Information blocking and emergency preparedness. And there are others that are coming up throughout the next year as well. So it's a really growing program for Sequoia. So let me tell you a little bit quickly about the Emergency Preparedness Work Group and our mission. So we were formed to really provide a forum to learn about health information technology innovations impacting emergency preparedness and response. Two things we like to say about this work group, the two really core features of this work group. First and foremost, I know Nora will say this, it is a community of practice. It is a safe place for people to come together and talk about the innovations that have worked for them and potentially the innovations in interoperability that have not worked for them. And then brainstorm with others and other experts around the country. So it's sort of unique in that respect that we are able to do that. Then the second piece of this is we want to take our expertise, our collective expertise, and build on that and create products, solutions, white papers, whatever it might be, that might be helpful to public health as they just start to address the next emergency. So that's sort of really the core of what we do. We are really looking at a variety of items, not just technology as it pertains to emergency preparedness and response, but policy and regulatory challenges. I come from state government, many years in state government. Boy, do we have policy and regulatory challenges. So we, as a work group, are considering these. What are some of the things we can do to be helpful? I think we'll talk a little bit later about one of the work products that's going to be coming forward in 2023 that would be helpful for that. Programmatic challenges, data and data privacy and security are obviously just really fundamental at the forefront with public health and emergency preparedness at the moment. Funding and resources, always a challenge, and communication between agencies or between those who are involved in emergency preparedness. All right, I'm going to stop there and ask Nora to come up and do a quick, or not quick, as long as you want to, introduction and talk about our work group and our members and give a little bit of background.
Okay, thank you, Debbie. I think I'm going to stay seated because I can trip over an invisible crack, and those lights are very bright. So I'm Nora Belcher. For those of you that don't know me, I'm the CEO and founder of the Texas eHealth Alliance. We are a 501c6 trade association in Texas. We cover the whole forefront of eHealth, from data to telemedicine and all of the things in between. I am a capital critter, as they say, with 30 years of experience at the Texas Capitol. I started when I was very young. I was 12 when they first let me start messing with legislation. And I do want to tell a personal story because I think Adam and I both have personal roots in this stuff. I was the healthcare advisor to the governor of Texas during Hurricanes Katrina and Rita. My team was on the floor of the Astrodome with the physician's desk reference asking evacuees, do you recognize your blood pressure pill? Do you recognize what you take every day? Because some of the folks we lifted out of Louisiana with Black Hawk helicopters, not only did they not have their pills, their doctor's office was underwater, their pharmacy was underwater, and one woman, I'll never forget this, the only ID she had was a gas station receipt with her name on it from her credit card. That's 100% of the information we had to try to help this woman in the middle of that crisis. And I told this story, Debbie and I presented at an emergency preparedness conference in Atlanta, and I was telling that story, and on the front row was an EMT paramedic from Fort Bend County, Texas, who was one of the people who was on the floor of the Astrodome. And he came up to me after the presentation and he said, I thought everyone had forgotten us. And I said, no, sir. Not only has nobody forgotten what you did, you should talk to Lee Stevens, the godfather of the Pulse Project, who at the time was at the Southern Governors Association when I was in a governor's office, and we started having these theoretical conversations about how could we make this whole situation better. So my passion for this topic comes very much from a lived experience of being in state government, working across the silos, not getting my phone calls returned, and not being able to use technology to help people in a crisis. And I really want to compliment the consumer work group real quick, because a lot of those issues they were amplifying in that discussion really sort of get doubled down on in an emergency. So not only are you sick, the world is on fire, or underwater, or shaking under your feet, or some other horrible thing. So out of the work that was Pulse, which is how I got to meet Marianne and start really working with folks from Sequoia Project, the idea of building out this bigger work group was very appealing to me. So I don't know how many Texans are in the room, but y'all may know that Matthew McConaughey is the Minister of Culture for the University of Texas, self-declared. I see my job as one of the chairs, because Adam does actual work, as the Minister of Culture for the culture of the work group. And that's why when we talk about community of practice, this work can be very isolating. So part of what we have wanted to build for our membership is that safe place to cheer each other's victories. We actually have an agenda item to cheer for each other. Who's got good news to report? Who's had a win? Who's had a success? Because this work can be hard and lonely and isolating, and we want our members to know that they're not alone in these really hard fights and be able to lift each other up, as well as, please tell me how you got your state health department to do that thing that I would also really like to do. So it's been a fantastic experience. This slide shows our membership, and so you can see here that we've got folks from state government, Medicaid, public health, all across the spectrum. I want to give a shout out to our two Cerner representatives who really are not representing Cerner, they're representing EHRA. Hans swore he would leave the room if I thanked him. He's still there, okay. And the reason that we did this is because we didn't really want a vendor presence in a literal sense, but you can't have these conversations without EHR vendors. So I want to thank EHRA and EHRA's leadership for stepping up and providing that resource to the group. We tried to get an early, easy win. That's another Minister of Culture. Yes, I totally learned all of this from Matthew McConaughey. I'm starting to figure out that's where my life roadmap came from, since we're both from the same year of the University of Texas. We really wanted to dig into the pandemic, right? And we really wanted to get in there and say, okay, we all knew it was bad. We all knew it was, pick your word, right? Unprecedented is my favorite center square bingo word, whatever word. But what did we learn, and how can we synthesize that into something useful? So we pulled the work group together and we said, okay, what will our process be? Next slide. And we chose to do a SWOT analysis. And if you've never done a SWOT analysis, they really bring out the best and the worst in people, because people have great ideas and people are really angry about things. So we built an online tool, and we asked everyone from the work group, come dump. Get it out of your system, write it down, and what we're gonna do then is pull themes out of that analysis, and it turned out to work really well for us. Next slide. So when we went through there, if you're not familiar with SWOT, it's a strategic planning technique, and you look at your strengths and weaknesses, which are typically internal, but not always. Sometimes they're your legislature. And then opportunities and threats, which can also be your legislature. They can also be very helpful. And that produced a set of recommendations that turned into a white paper, and I'm going to back over to Debbie to walk quickly through the work product of the work group. This was our first big statement.
Yes. Before we do that, and I know I was flipping through slides really, really quickly, let's get
Adam.
Quick introduction from Adam, and your passion.
All right. Well, as Debbie said, my name is Adam Harrell. I am a recovering paramedic. I've been a paramedic for 20 years, and people always ask, how do you end up dealing with data and IT as a paramedic? And I always joke because I met my wife of 20 years in the back of an ambulance. And we got married very young, very quickly in rural Southern Virginia. So most people have heard of a shotgun wedding. This was very akin to that. And I also have a sister who is exactly 2 weeks older than my wife. They're both named Christy. So when we got married, she became Christy Harrell, and I already had a sister named Christy Harrell. And we had a lot of challenges early on in our marriage with health and healthcare. And one of the things that really became interesting is take a rural hospital that's not part of a big, Centera or HCA or anything like that, that had a mix of paper chart at the time and electronic charting, and give them 2 young ladies that are the same age and have a birth date that's only a couple of days off. You can imagine what came out of that. And especially when you're having a lot of challenging healthcare issues at that age. We were, both in college, both very poor, and trying to work through that. I just looked at folks, everybody in this hospital we knew. We grew up with these people, we went to school with them. And at the time, my wife and I were both in school for healthcare. She wanted to be a nurse, I wanted to be a paramedic. Bad decisions, but we live with them. And then my sister was also in nursing school with my wife at the same time. So you really want to compound that problem. They both graduate nursing school. They both become nurses. And they both work in the intensive care unit in this local community hospital. And, you think it's bad when they screw up their medical record and their prescriptions. But let's put them as people who are charting in a new system, both paper and electronic. So probably the funniest thing was always the patients, because my wife worked first shift, which was 12 hours, and my sister worked third shift. And the nurse manager always thought it was hilarious to schedule them the same patient assignments. So these patients that are in just, comatose and drugged up, they have the same nurse, Christy Harrell, RN, 24 hours a day. So I took that, I've always had a passion for technology and said there've got to be things we can do to fix this. And I went to work in compliance at that hospital that ultimately led me to the Department of Health. But now looking at that from an EMS perspective and a disaster perspective, disasters are always local. So what you may consider a disaster here in DC is not the same thing for my hometown of Halifax, where we had, 20,000 people on a good day, and everybody knew everybody. Having two people with the same name and a date of birth that was only a couple of days apart was always a disaster. And then you add them as charters, and it makes it even more of a disaster. And let's put that in the context of the things like it's on fire and it's shaking and everything else is going on. How do we ensure that all of that is accurate? So as a kind of a long story, to bring it around to how I got into this, it's always been my passion to find ways that technology can help improve a problem, and the work with the Sequoia project, especially with Debbie. I've known Debbie for a number of years, and as I said yesterday, prior to a year ago coming onto this work group, I couldn't spell TEFCA, and it's become part of my everyday life now. So I'm very excited to be here.
Sorry about that, Adam.
So yeah, we can go on ahead here, but yeah.
Thank you so much. So you can see from their descriptions of how they got started that this is a really great fit for them to work with Sequoia and to work with this work group in particular. So I want to run through some of the recommendations, and there were 23 recommendations in our report, and it was entitled Insights on the Pandemic and Our Response, Emergency Preparedness Response. And as Nora mentioned, we spent a good deal of time with the work group, and we did it's sort of an interesting approach to SWOT analyses, I think, that I've worked with before, is we really opened up. We meet monthly with the work group, and we really opened up the first few months to just throwing things out there, just brainstorming, whatever that might be. And then we spent time synthesizing that information into the proper category. Now, when you do a SWOT analysis, you've all seen this happen before. Where you think you have a strength, you also see that you have a weakness, and it's the same thing. So we spent some time synthesizing that, and then we're able to come up with a set of recommendations. Again, this was published earlier in the year, and it is on our website, on the Interoperability Matters website, if you'd like to download it. So for the sake of time, and not to bore you with 23 recommendations today, we did sort of put these in categories. And I want to mention something that really kind of resonated throughout all of our recommendations, and that has to do with equity. Health equity, and making sure that there's equity in everything we do, in our work group, in our recommendations to public health, and considering health equity in everything we do, and access to health care. So the first set of recommendations was around data, and sort of the data itself and the data infrastructure on which the data resides. So we also did, in the process of creating these recommendations, sort of interviews with other public health folks as well across the country to ask them about, you're in the middle of the trench, you're in the trenches right now, responding to the pandemic. What are some of your thoughts here? And one of the things that really resonated was, let's build on existing infrastructure. Now, health departments across the country, as you all know, are pretty disparate in where they are with infrastructure, whether that's data or whether that's technology infrastructure itself. But what really resonated with the work group is that instead of ripping and replacing, sometimes it's okay to build on what works already. And I think as a work group, we've been very mindful of sort of following that mantra and thinking about, with public health in particular, what are the things that are working well, hence our strengths as part of the SWOT analysis, and how do we build on those instead of pulling them away. And the other piece of that is with public health and the way that the public health agencies have really had to step up during this pandemic. It's time to recognize some of the really good work they've been doing. I think, it has shown us, the pandemic has shown a spotlight on some of the areas where things might be lacking. But shining a spotlight on some of the things that are really working well was important to us and important to call out in our report as well. So evaluate data analytics capabilities. A lot of the recommendations you're going to see in here have to do with evaluating things or taking a look at what currently exists and seeing if we might be able to build on it. Sharing information bidirectionally was certainly, in terms of data, was certainly a key message that sort of was threaded through our entire report. We focused on vaccination records because certainly that was very critical during the pandemic and continues to be. And again, this concept of equity and vaccination equity and data stored for vaccinations, immunization registries, things like that was a conversation that was had with the work group. And you guys stop me if you have any comments along the way. All right, then we had recommendations around one that I kind of laugh at since I spent 32 years in state government, address policy confusion. Ha ha, I don't know how to do that really. There is so much, I think, confusion, and I think back to my time in public health where I interpret a policy a certain way, and I think, and then others interpret the policy a little bit differently. And there is this tendency to, whatever you're driving forward, interpret that policy to help inform what you're doing. So I think that, and there's also so much duplicity, and there's, there may be policies that may be conflict with one another now or are not that current. And I'll just speak to my experience in Virginia, and I think Adam can probably speak to this way better than I can since he's still in state government, with the fact that a lot of the policies and regulatory issues that state governments and public health are dealing with right now, these policies and laws on the books and so forth have been there for sometimes decades and have not been updated. So now is the time to start thinking about how do we address those policies that are really need to be updated in order to inform interoperability. And we've got a little bit of information on that later in terms of a next deliverable that the group is working on. Then understanding funding opportunities and policies around funding opportunities, difficult challenge for public health. And then develop funding, sustainability, and matching policies. So sustaining fundability, again, is sort of a tough one. There tends to be, in a situation like the pandemic, a great deal of money coming to public health. Sometimes that's a one-time thing, but technology is not something that you build once and it's there forever and it works and you never have to worry about it again. It's like your electricity, right? You pay your bill, you flip the switch, and it comes on. And technology kind of works the same way. So some recommendations around that. Again, equity, healthcare equity, expand access to the prescription monitoring program, and the data that is part of the PMP. So that's a topic that really has some interesting discussion when you start having conversations with folks around access to prescription monitoring data. And that is really managed by law in every state, and that can be different in other states, but we have a recommendation. And again, I'll mention if you want to download the report does have specific examples and details in the report. And then look at legislative policies and regulatory constraints for data sharing. And as some of this really fits into the conversations around information blocking, public health, and thinking about public health and information blocking, it's an interesting discussion. How much of that information, de-identified information, is public and how much is not public. So we had quite a bit of discussion, a lively discussion, I will say, about that. Then we had several recommendations around communications, in particular leveraging the lessons learned from other states. And our work group is doing a really great job of bringing together, again, these experts from other states, enabling those conversations. Identify state and local emergency response workforce resources and capabilities. We have a similar recommendation around doing an inventory of existing technologies and data capabilities. And obviously, these recommendations look pretty similar to other reports that have come out that I've seen. So I think we were in alignment with what others have seen as they've worked on this same problem. Stop duplicative efforts, which is another tough one. And then share communication strategies. Good.
You have to try.
You have to try.
You have to try. That's what we kept telling ourselves. Some of this felt reachy, but at the same time, it's like you can't not do it, as has been said many times today. You have to keep trying in this really complex landscape. And I think it's important to make that statement out loud, and there have been several statements made out loud like that today. So I think that's the one from the EPIW. Yes. You have to keep, even if you only just get one regulation, that's one regulation. That's right. I like that. Let's do more of that.
Right. All right, then our next set of recommendations were around innovations. And this is one of my favorites. Reconcile big ideas with realism. It's one of my favorites. It really resonates with me that we, and the work group as well, I think during the pandemic we noted, and members of the work group noted that innovations came flying, fast and furious. And there had to be a dose of realism in there in terms of, whoa, we're public health, we're in the middle of a pandemic, we cannot evaluate every innovation and make a decision and implement every innovation. So this reconcile big ideas with innovation and with realism was sort of a key strategy and recommendation. Address public health and emergency response IT infrastructure. This sort of plays back to the recommendation I mentioned earlier. This was really around data modernization, IT modernization, which is certainly something that CMS, ONC, and other entities at the federal level are recognizing and working with state governments on. And then address or assess, public health emergency response technology tools. So the tools, as we discussed this within the work group, the tools that we found sometimes work really well for one locality or one state government, but that was not consistent across the country. So we had recommendations around how we might get there. All right, so that kind of sums up a sampling of the recommendations that the work group had. I wanted to pass back over to Nora and Adam and have you all speak to the sort of overarching goals that we prioritized in 2022 and what we're looking to do in 2023.
Absolutely. So one of the big things is, again, I represent emergency medical services for the Commonwealth of Virginia. So that's like 600 agencies, 1.9 million patient interactions a year that may or may not end up in an emergency department or receiving facility. So the first thing I would say is, if you're not an EMS person, and I don't recognize a lot of you, it's a small community, but try to engage your state EMS folks. We're looking for more of that. There's valuable information to be found in EMS. They want healthcare data. They want the hospitals. They want outcomes data. And it's honestly a very lucrative two-way street, both in information as well as the bottom line. So, as we're looking for new membership, try to help us recruit some of those EMS folks from your respective areas.
Well, and I think what Adam's really hitting on is the idea that we are going to become more than just emergency preparedness as a work group. Because really this becomes about public health at the end of the day, and you can't untangle them enough to make them separate. So in terms of who we're looking for, we want people who have frontline experience, and we are looking for people who are not afraid of the three of us. Because here's the deal, as any work group member in this room will testify, we will call on you if you don't talk. So if you are a person that likes to lurk on calls and never talk, do not come try to be on our work group, or come get over your shyness. You have choices. You can make choices. We really are looking for contributors, and I joke about it because I understand not everybody has an overly exuberant, talky personality, but if you've got good stuff in your brain, I'm going to get it out of you one way or the other. So we really want people who have passion and enthusiasm for this particular area of expertise. Adam is such a great example. He has already elevated our game significantly. Is he blushing yet? I'm working on it. Okay. Because he's a frontline person. I operate in policy, he operates in operations, and we know those two worlds don't always talk to each other. So if you do one, or if you do both of those things, and this is interesting to you, come talk to one of us about participating.
Well, even more when you talk about public health, you talk about the Virginia Department of Health alone, and I'm going to steal Debbie's phrase from yesterday. If you've seen one public health agency, you've seen one public health agency. We deal with everything. It's emergency medical services. We certify trauma centers. We deal with poison control. But then there's also drinking water and septic systems and environmental health, as well as we have 35 local health districts that are actually treating patients every day that are managed by us. So, there's kind of a lot of what we're talking about. There's the practice of public health, and then there's the study of public health. And when you talk about emergency preparedness, that's where both need to come together, and we need people in both of those areas around public health, and then outside of public health as well, because there's a wealth of information to be shared bi-directionally.
Mm-hmm. So to follow up on both of those comments, the sort of key piece that brings these two sort of disparate policy and operations together is that of data and the exchange of information and providing data and the exchange so that we are in real life situations that Adam spoke to and Nora has experience with as well, is that we're providing, again, the right information at the right location during an emergency. And having a person who's in the middle of a hurricane, have lost their home, whatever it might be, and they're having to look at a piece of paper and identify whether or not that looks like their medication, is unacceptable. And obviously, I think we've come a long way, and there are certainly innovations in place now that would be helpful in that situation, but we still have a long way to go in terms of emergency preparedness and response and public health. And at the Sequoia project, we are very interested again in synthesizing, boiling this down to some really actionable items that Sequoia can be helpful. As Mary Ann mentioned earlier, we like to take real life problems and solve them and try our best to come up with things that can be implemented at a national level. And this emergency preparedness work group is really sort of elevating that and helping us to get there. So in 2022, our priorities were, as we sort of ramped up with our emergency preparedness work group, our priorities were to work on things that we could turn around pretty quickly. So our white paper around the pandemic was put out. And then we certainly continued to provide that community of practice. But we have some significant upcoming milestones and deliverables we want to talk to you all about. And then I'm going to mention them briefly, and then I'll pass off to Nora and Adam for comments on those. So we are looking at our future deliverables. We're going to, as we said, supplement the recommendations report that we put out. One of the things that really came out loud and clear to us is that we need some kind of public health policy, and we're talking about interoperability here, roadmap. And this is something we've started and we've been working on for some time. This requires our work group, though, to do quite a bit of outreach to other subject matter experts within other states that are not represented on our work group. We want to make sure we hear from folks and experts so that we've got this covered. So we're really interested in providing this roadmap to say, hey, public health, if you're trying to inform interoperability, progress interoperability in your state and in your locality, in your agency, take a look at this roadmap. Here are the things that you need to be considering in your policies and where you might look. And so we hope to release that around the first quarter of 2023. The other piece of that will include, and we found this to be true with public health as we've had conversations with the public health folks in the country around TEFCA, and there are varying degrees of understanding of TEFCA in public health. As Adam mentioned, he hadn't really heard about it until sort of recently. And obviously, if you're in public health and you've been responding to a pandemic, TEFCA might not have been your priority. I can't imagine why, but it might not have been your priority. So what we intend to include in our next deliverable is a sort of a public health workflow tool for TEFCA. So we're going to take a real life use case like cancer registry, for instance, and map out, here's how the cancer registry may currently work. And if we insert the concepts of TEFCA, here's how we might enhance interoperability and enhance data sharing within this particular tool that you already use. So we're also in the process, and I mentioned this yesterday in the other panel, that we are in the process of creating a public health state SOP for TEFCA as well. So I want to hand off to Nora and Adam, start with Nora, to sort of describe some of the changes we've got coming in 2023.
So I made reference to this a little bit earlier. Emergency preparedness is an insufficient term for the landscape that we are managing. So we are looking at a rebranding around the name. We are looking at expansion to bring some additional folks into the work group, both from a subject matter expertise to complement the folks we've already had and to help us take on this bigger idea. The thing I would say about TEFCA is I spend a lot of time in meetings where people argue about nouns related to TEFCA, and the nouns are important. I think what we want to be about is the verb, and how does the verb of exchange play out in public health so people don't get caught up in what is the noun and they're more focused in the verb, because emergency preparedness public health is a verb land littered with nouns that are in the way. So we just want to try to get folks who want to take action, who can take action, have an interest in solving problems, who've been obsessed with data for years, and leverage their expertise to do that expansion and that rebranding. And I think that's going to lift us all up to another level, and it complements the overall goals that Marianne and Sequoia have laid out really beautifully.
And from a state's perspective, if you wait until you need to be interoperable with data, or you wait until the point you need to share data to say, all right, we need to check our policy and see what we can do, you're too late. And then utilizing TEFCA framework, and that's the big piece with the roadmap for policy, especially in public health, is making sure that those policies are open and future-proofed. I mean, we like to be very restrictive in state policy and in law, but ultimately, when you want to talk about interoperability, there need to be some caveats built in there. So, if you're a policy nerd or like law and policy, I don't know who would like that type of stuff, but we need those type of people on this work group too.
Mm-hmm. Yeah. So to sum up what they're saying, so in 2023, we are looking to, again, expand our scope. Emergency preparedness and response is a huge component of public health, but it's not everything. And we're looking at how can we be helpful from a national landscape in terms of the work that's going on in just syndromic surveillance, not during an emergency. What are some of the things we can do in terms of HIPAA, for instance, or be helpful there, a minimum necessary with public health. So this is I'll use this phrase when I worked at the health department as well. Some people used to ask me, do you like your job at the health department? And I would say, it's an environment rich with opportunity. And I think this is still suitable here. How do you like working on the Emergency Preparedness Information Work Group? It's an environment rich with opportunity. So we've done so many good things, but there's work to be done. So I'm really thankful again to be working with Adam and Nora to be doing this work. So again, we're looking for expanded membership in 2023. We will be probably changing our work group name to more of a public health focused broader scope name. So if you've got any ideas there, please ask us or tell us. And I think that might be all of our slides. So if you want to get involved, there's my email address, and you can certainly contact me or get in touch, and we'd be happy to give you more information about the work group. I'm going to ask Adam really quickly one more question. I think we only have a few minutes left. And then I want to open up for questions from you all as well. But one more question to you, Adam. So of all of the things that you do during the day and the work that you have to do at the health department, why join the Emergency Preparedness Information Work Group? And not because I twisted your arm.
Because Debbie asked very nicely. No, you know, like I said, before I had spoken with Debbie about this, I couldn't spell TEFCA. I didn't know what it was. And now, you know, joining the Interoperability Matters work group and the work that we've done and becoming the co-chair with Nora, you know, I've worked with a lot of other people. Not having to reinvent the wheel, you know, has been great. You know, networking with other people within the industry, within data. But also, you know, we've gotten to where we include TEFCA elements in the things that I'm pulling out of this work group in our procurements, in our RFPs. Our normal standard operating procedures have the principles of TEFCA built into them now. So that aspect is amazing.
That's wonderful. I think Mary Ann's head just exploded over there.
Actually, I think Adam is keynoting an upcoming conference in Austin, in my hometown, where he's going to be integrating these concepts into his presentation. It's an EMS conference, if I'm remembering correctly.
It is.
I mean,
yes.
We were not there 18 months ago with the crossover between those spaces the way we are now, and that's a credit to Debbie, who is completely amazing, and to Mary Ann, and to the willingness of everybody to come into this group, drop the walls, drop the shields a little bit, and work as a team. That's when you can really accomplish great things. So it's pretty cool.
You're here. All right, we have 2 minutes left. Anyone, any questions from the audience?
Good. Hi, great work group, great activity. You know, looking forward to where you take this going forward. You know, I feel a little bit like a parent, you know, with several children, and how do you decide which one you favor? But there's something special about this work group, in particular because of my earlier comment in some of the opening statements about the state of public health in this country. But so this is really not a question, it's more of a comment. There are two things that keep rattling around my brain, concepts. One of them has to do with paving over cow paths, which is, you know, I think most people understand, is the idea of using previous business practices but applying new technology to the same old stuff. And the other one, the other concept has to do with leapfrog technology. And, you know, this is an example in the third world, for instance, where telecommunications skipped the fixed line era because they didn't have it, and they didn't want to invest in it, and they moved directly to cellular. And so as we think about innovation going forward in public health, you know, I guess I want to encourage us to, you know, sort of think out of the box. You know, let's not just think that we'll solve the problem by deploying current technology or current old technology. But, you know, how can we utilize new technologies, new communications capabilities, the internet and so forth, to at least inform certain use cases within public health? I mean, there are many use cases that need to be solved, but, you know, one of the things that I thought was remarkable was when I got my COVID vaccine, all of a sudden I was enrolled in this V-Safe program, and periodically I'd get these text messages asking me to tell them how I was doing, you know. And, you know, they had smiley faces or frowning faces about how I was feeling and so forth. I mean, you know, that's just, to me, it's just sort of one simple example of how we might be able to be innovative in the public health space, at least for certain use cases.
Thank you. That's a great comment. And I think to that point, if now is not the time to elevate public health to where it should be, I'm not sure when that is. You know, it's unfortunate, I think, that we had to go through a pandemic to shine a spotlight on that. But now I think we are all there, that this is the opportunity. It just feels like we're right on the cusp of doing some really great things with and for public health. So we're excited about that. We're excited about that with the work group. I don't know if we have time for one more question or if we have any more questions. We can't see, so.
It's okay. I'll make mine quick. Thank you. Great work. Just two things that come to mind for me. One is that in some of the work that Cedar Bridge Group has done for researching the issues around this broadband, and so, kind of weaving that together so that connectivity is also, available. And the second is to not forget environmental risks of, some public health workers like wildland firefighters, my personal passion, but, there's agricultural risks and all kinds of other workplace hazards that is a total public health crisis as well. So I just wanted to bring those up and think about as you're, building out your agenda that you keep those in mind.
Thank you. Thanks. Thank you. One more, and then we will wrap up.
Just a quick comment following on one of the things Adam said. It occurs to me that if we want to really be ready for the next pandemic, focusing on that particularly, we need to be using the approved standards for our daily work with the things that we do every day with lead levels and with reportable diseases and other things. And if we don't do that, we won't be ready because we won't have the infrastructure and the standards available to do that. And so I think that, just a comment that I think we need to focus on using the tools that we want to use in the next pandemic every day to do our work, and then we'll be ready for the next pandemic.
Thank you. That's a great comment. And I think you can see from some of the comments so far and the suggestions that, again, it is an environment rich with opportunity, and we have our work cut out for us, but we are up to it. So we will continue to keep you all updated on our work in 2023. And Adam and Nora, again, thank you so much for being my partners in crime, and thank you all.